Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 307 of our pharmacotherapy series, which majors in cardiac arrhythmias. The first question reads, JKL, a 66-year-old man, presents for a routine checkup in the clinic. His medical history includes type 2 diabetes mellitus and systolic heart failure for the last 5 years, hypertension, and gout. There is no history of rheumatic heart disease, myocardial infarction, pulmonary embolism, or thyroid disease. His medications include metformin 1 gram twice daily, lisinopril 40 mg every day, furosemide 40 mg twice daily, metoprolol succinate 50 mg twice daily, and allopurinol 300 mg per day. JKL does not smoke or drink alcohol. Physical examination reveals a blood pressure (BP) of 136 systolic, 84 diastolic, pulse of 70 beats per minute in normal sinus rhythm, respiratory rate of 12 breaths per minute, and temperature of 98.2 degrees Fahrenheit. His body mass index is 32 kg per meter squared. What factors in JKL's past medical history predispose him to development of atrial fibrillation? What is his 10-year risk of developing atrial fibrillation? Atrial fibrillation is commonly associated with, or a manifestation of, other diseases or disorders. When treatable underlying causes are present, they should be corrected because this may resolve the atrial fibrillation. A risk prediction tool highlights common factors associated with the development of atrial fibrillation, particularly older age, male gender, hypertension, heart failure, obesity, and valvular disease. In a small percentage of patients who do not have underlying heart disease, atrial fibrillation is called lone atrial fibrillation and usually has a more benign course. JKL has several risk factors for the development of atrial fibrillation within the next 10 years, including the presence of treated hypertension, heart failure, his age, and his sex. Using his risk factors, his 10-year risk of developing atrial fibrillation would be greater than 30%. The next question reads, 2 years later, JKL presents with complaints of dyspnea on exertion, abbreviated as DOE, and palpitations for the last 2 weeks. He experienced palpitations of shorter duration 3 times in the last year, but these were not associated with dyspnea on exertion. On physical examination, he is found to have rales. Cardiac examination reveals an irregular rhythm without murmurs, gallops, or rubs. His jugular veins are distended 4 cm, but no organomegaly is found. His extremities have 1+ pitting edema. The ECG shows atrial fibrillation and the chest radiograph is compatible with mild pulmonary congestion. A cardiac echocardiogram reveals the atrial size to be less than 5 cm normal, and a left ventricular ejection fraction of 35%. What clinical findings demonstrated by JKL are typically associated with atrial fibrillation? What are the likely consequences of his atrial fibrillation? The most common complaint in patients with atrial fibrillation, as with JKL, is palpitations, the sensation of the heart beating rapidly or unusually in the chest. This is a result of the rapid ventricular rate, which typically ranges from 100 to 160 beats per minute. The RR interval time from the R wave in one QRS complex to the R wave in the next complex is a regularly irregular, random irregularity. During atrial fibrillation, the atrial kick or the atria's contribution to stroke volume is lost. Because the atrial kick may account for 20% to 30% of the total stroke volume, this, coupled with rapid ventricular rates and irregular RR interval spacing during atrial fibrillation, can cause symptoms of inadequate blood flow such as lightheadedness, dizziness, or reduced exercise tolerance. However, some patients are asymptomatic except for the palpitations. Depending on the underlying ventricular function, signs of heart failure, such as dyspnea on exertion and peripheral edema, may develop, as experienced by JKL. Conversely, underlying heart failure may precipitate atrial fibrillation. Patients with atrial fibrillation are at risk for thrombotic stroke. With the chaotic movement of the atria, normal blood flow is disrupted, and atrial mural thrombi, usually in a pouch called the left atrial appendage, may form. The risk of stroke increases after restoration of normal sinus rhythm, which allows more efficient cardiac contractility and expulsion of the thrombus. Patients with nonvalvular atrial fibrillation have a fivefold increase in the risk of stroke. This risk increases as patients have an increased number of associated risk factors. Other concurrent diseases that may increase the risk of stroke are heart failure, cardiomyopathy, thyrotoxicosis, congenital heart disease, and valvular heart disease. Because of the high risk of stroke and significant impact of stroke on patient outcomes, pharmacologic stroke prophylaxis is often indicated. Selection of an appropriate antithrombotic regimen for the patient with atrial fibrillation must be based on assessment of the underlying stroke and bleeding risk. Risk stratification in atrial fibrillation is performed with the use of the CHA2DS2VASC scoring system. HR2DS2VASC score is calculated by assigning 1 point each for the presence of congestive heart failure, hypertension, diabetes, vascular disease, age of 65 to 74 years, or female gender, and 2 points for age of 75 years or greater or a history of stroke. Points are totaled, and the subsequent score correlates with stroke risk. The next question reads, what are the therapeutic goals and general approaches used to treat atrial fibrillation in patients like JKL? The two primary goals of treatment are to control the ventricular response rate and to reduce the risk of stroke. In some cases, a third therapeutic goal may be conversion to normal sinus rhythm. The next question reads, JKL is given a 1 mg loading dose of digoxin, followed by a 0.25 mg everyday maintenance dose. What is the purpose of administering digoxin? What are the relative advantages and disadvantages of digoxin compared with other agents to control ventricular rate? The first treatment goal is to slow the ventricular response rate, which allows better ventricular filling with blood. Because of its direct AV node blocking effects and vagomimetic properties, digoxin prolongs the effective refractory period of the AV node and reduces the number of impulses conducted through the AV node, which is referred to as negative dromotropy. There are several limitations associated with digoxin use in atrial fibrillation. Digoxin has a slow onset of action. After an intravenous IV dose, it will take more than 2 hours for the onset of effect and 6 to 8 hours for the maximal effect, which is markedly slower than other negative dromotropic agents. Digoxin is also less effective than beta blockers and non-dihydropyridine calcium channel blockers during states of heightened sympathetic tone, e.g., exercise or emotional stress, a common precipitant of paroxysmal atrial fibrillation. The 2014 American Heart Association, American College of Cardiology, Heart Rhythm Society Guidelines for the Management of Patients with Atrial Fibrillation recommend that digoxin use be reserved for control of ventricular response rate in patients with impaired left ventricular function or heart failure, or for use as an add-on therapy when treatment with a beta blocker or calcium channel blocker provides inadequate rate control. Patients who require rate control of atrial fibrillation and have a lower BP may also benefit from rate control with digoxin. It should also be noted that digoxin serum concentrations may be increased when combined with P-glycoprotein inhibitors such as verapamil, propafenone, quinidine, flecainide, and amiodarone. Normally, P-glycoprotein in the brush border membrane of intestinal enterocytes pumps digoxin into the lumen of the gut, reducing its bioavailability, and pumps digoxin out of the body via the renal tubules. The next question reads, JKL has diabetes, which increases the risk for diabetic nephropathy. Would the dosing be changed if JKL had renal dysfunction? JKL's renal function is normal. If he had significant renal dysfunction, both the loading and the maintenance doses of digoxin would need to be altered. A loading dose is used to achieve a therapeutic level, and volume of distribution of digoxin is reduced in patients with renal dysfunction. The digoxin maintenance dose is highly dependent on renal clearance, because digoxin is eliminated 50% to 75% unchanged in the urine. Although the usual digoxin target range is generally 0.5 to 1.0 nanograms per milliliter in the management of patients with heart failure, higher serum concentrations may be necessary when using digoxin as a rate control agent for JKL. The next question reads, what other drugs can be used for ventricular rate control, and what are their relative advantages and disadvantages compared with digoxin? Beta-adrenergic blocking agents are another class of negative dromotropic agents used in atrial fibrillation. Propranolol, metoprolol, and esmolol are available for IV administration. Each agent rapidly controls the ventricular rate both at rest and during exercise. Beta blockers are the first choice in high catecholamine states such as thyrotoxicosis and post-cardiac surgery. However, given the negative inotropic effects, beta blockers should be used cautiously to acutely control the ventricular response in patients with decompensated heart failure. Even though beta blockers are used to treat systolic heart failure, e.g., bisoprolol, carvedilol, and metoprolol, they need to be started at low doses and titrated slowly for several weeks to therapeutic doses. When trying to achieve rapid rate control, more aggressive dosing may be needed. Beta blockers should also be avoided in patients with asthma because of their beta-2 blocking properties, and blood glucose levels should be monitored more closely in patients with diabetes mellitus because the signs and symptoms of hypoglycemia, except sweating, can be masked. Next we will look at calcium channel blockers. Non-dihydropyridine calcium channel blockers are also effective in slowing ventricular rate at rest and during exercise. Both verapamil and diltiazem can be administered IV for a rapid, 4 to 5 minutes reduction in heart rate. Non-dihydropyridine calcium channel blockers should not be used in patients presenting with decompensated heart failure. They work through their effect on slow calcium channels within the AV node. Although the duration of action produced by bolus dosing is short, both agents can be administered either as a continuous drip or orally. Given the ability of calcium channel blockers to cause arteriolar dilation, a transient decrease in BP may be seen. IV calcium pretreatment can be used to attenuate the BP decrease among patients with hypotension, near hypotensive BP, or left ventricular dysfunction. Calcium pretreatment does not appear to diminish the negative dromotropic effects of non-dihydropyridine calcium channel blockers. Verapamil is contraindicated in patients with an ejection fraction less than 35%, and diltiazem should be used with caution in heart failure with a reduced ejection fraction. Verapamil increases the concentrations of other cardiovascular drugs such as digoxin, dofetilide, simvastatin, and lovastatin. Verapamil and diltiazem are good alternatives to beta blockers in asthmatics. For chronic therapy, oral negative dromotropic agents, usually a beta blocker or non-dihydropyridine calcium channel blocker, are recommended. If higher dose monotherapy with one of these drugs is needed to control symptoms but is associated with intolerable side effects, adding lower dose digoxin to a beta blocker or calcium channel blocker is recommended. JKL has signs of mild heart failure, so digoxin is a reasonable choice, although short-term IV diltiazem is often used in this type of patient as well. IV verapamil and beta blockers may worsen the signs and symptoms of heart failure, and the beta blockers may mask signs of hypoglycemia in JKL. The goal of rate control should be a resting heart rate between 60 and 80 beats per minute and an exercising heart rate between 90 and 115 beats per minute. A recent study has explored the use of a more lenient target resting heart rate less than 80 beats per minute. This study may suggest that it could be acceptable for a patient's heart rate to be greater than 80 beats per minute, if there is difficulty in achieving this level of heart rate control and in asymptomatic patients or those with heart failure. And a preserved ejection fraction. The next question reads, after loading of digoxin, JKL's heart rate is still 120 beats per minute and he continues to experience palpitations. His BP is 100 systolic 60 diastolic, and his symptoms of heart failure are improving, but he still complains of mild shortness of breath. The decision is made to cardiovert JKL to normal sinus rhythm. Is JKL a good candidate for a rhythm control strategy, and if so, why? What is the likelihood that JKL will be successfully converted to normal sinus rhythm? The use of a rhythm control strategy has become much less common during the last several years. This change is because of the completion of several studies comparing the effect of a rate or rhythm control strategy on patient outcomes. The AFib study, which is an abbreviation for Atrial Fibrillation Follow-up Investigation of Rhythm Management, a randomized, multi-center study, was one of the largest to compare rate control with rhythm control for management of atrial fibrillation. AFib enrolled 4,060 patients with atrial fibrillation and a risk of stroke. The primary endpoint was all-cause mortality. Antiarrhythmic drugs were chosen at the discretion of the treating physician, but greater than 60% of the patients received amiodarone or sotalol as the initial antiarrhythmic agent. Rate control agents included digoxin, beta blockers, and non-dihydropyridine calcium channel blockers. After a mean follow-up of 3.5 years, there was a trend toward lower overall mortality, with a p-value equal to 0.08, with significant reductions in hospitalizations 10% lower, with a p-value equal to 0.001, and Torsades de Pura, abbreviated as TDP, 300% lower, with a p-value equal to 0.007, in the rate control group. Therefore, using rhythm control in patients with atrial fibrillation rather than rate control does not improve outcomes and increases the risk of hospitalizations and torsade de poids. The default long-term treatment strategy for most patients should be a rate control strategy, in which heart rate is controlled and anticoagulation is provided, if indicated. However, rhythm control is necessary when patients experience symptoms despite adequate rate control, when heart rate cannot be adequately controlled with currently available treatments, or if patients cannot tolerate the adverse effects of rate-controlling medications. JKL's heart rate is not adequately controlled with digoxin and an oral beta blocker. A non-dihydropyridine calcium channel blocker could be added, or the beta blocker dose could be increased in order to better control his heart rate. However, his BP may not tolerate the increased dose of the beta blocker or the addition of a non-dihydropyridine calcium channel blocker. Therefore, pursuit of a rhythm control strategy is warranted. Likelihood of successful conversion to, and maintenance of, normal sinus rhythm is determined by the duration of the arrhythmia, underlying disease processes, and left atrial size. Duration of atrial fibrillation for more than 1 year significantly reduces the chances of maintaining a normal sinus rhythm. When the atrial size exceeds 5 cm, there is less than a 10% chance of maintaining normal sinus rhythm at 6 months. JKL's chance of being maintained in normal sinus rhythm is good because the duration of his atrial fibrillation is short and the echocardiogram revealed only slight enlargement of his left atrium. The next question reads, warfarin treatment is begun and JKL's prothrombin time is to be maintained at an international normalized ratio (INR) of 2 to 3. JKL is scheduled for a transesophageal echocardiogram, abbreviated as TEE, to determine whether cardioversion can be performed during this admission. How does a transesophageal echocardiogram help to determine whether cardioversion can be performed, and why is warfarin therapy being used? When the onset of atrial fibrillation is less than 48 hours, the likelihood of atrial clot formation is low. However, if patients are at a high risk for stroke, they should receive an anticoagulant, such as an unfractionated heparin, a low molecular weight heparin, a factor Xa, or a direct thrombin inhibitor, as soon as possible surrounding the cardioversion, followed by long-term anticoagulation. When the duration of atrial fibrillation is greater than 48 hours, or if duration is unknown, then an oral anticoagulant agent, such as warfarin, dabigatran, or a factor Xa inhibitor, should be given for 3 weeks before cardioversion at doses providing an INR between 2 and 3 if using warfarin. Studies in patients with atrial fibrillation showed that those who were anticoagulated with warfarin before cardioversion had a lower incidence, that is 0.8%, of emboli than those who were not anticoagulated, that is 5.3%. Alternatively, a transesophageal echocardiogram can be used to determine whether atrial clots have formed. Atrial clots form most often in small side pouches on the atria called atrial appendages. Because the frequency of right atrial appendage thrombosis is half that of left atrial appendage thrombosis in atrial fibrillation patients, the risk of stroke is enhanced much more than the risk of pulmonary embolism. If no clot is observed on transesophageal echocardiogram, then there is low risk for stroke with cardioversion of atrial fibrillation. However, if an atrial clot is evident on transesophageal echocardiogram, JKL would need to be adequately anticoagulated for 3 weeks before cardioversion to prevent embolization of the clot and stroke. If cardioversion is successful, patients should remain on an oral anticoagulant agent for at least 4 weeks after cardioversion because normal atrial contraction may not return for up to 3 weeks, and patients may be at risk of late embolization. The decision to provide long-term oral anticoagulation is dependent on the patient's underlying stroke and bleeding risk. This will be discussed further below. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 308.